I'll be talking about MR imaging of stroke and stroke mimics, a 4-question-based approach. So how many here see stroke patients in their practice? That's a decent number. And stroke mimics like migraines, headaches. All right, good. So stroke imaging is a very complicated topic, but this is a very simplified 4-question-based approach to simplify the approach on MR imaging of stroke. All right, so a 53-year-old male comes to the ED with left-sided weakness for unknown time. And this is what the DWI shows. So on the diffusion weighted, you see a large area of diffusion restriction. You can see hyperintensity on DWI and hypointensity on ADC, consistent with diffusion restriction in the distribution of the right MCA, consistent with acute infarct, something which we routinely see. So the discovery of the diffusion EPI sequence on MRI revolutionized stroke imaging, and there hasn't been any turning back. The echoplanar imaging of diffusion was applied in brain imaging in 1991, and which helped in diagnosis of stroke. And after that, this has been the most important sequence in stroke. So let's go to the 4-question-based approach on stroke imaging systematically. The first question should always be, is this an infarct on MRI? The next question should be, how old and large is the infarct? Can I actually date it on MRI? The third question, can I actually apply newer imaging technologies to help the physician in diagnosis? And then finally, am I sure this is not a stroke mimic? Is this actually stroke? So let's start with the first question. Is this an infarct on MRI? And that depends upon multiple factors. The most important is clinical history. Does the clinical history match? Was the symptom onset actually acute and sudden, or was it more gradual? Is the lesion which I am seeing in a vascular distribution? And finally, is there diffusion restriction in that distribution? So the vascular distribution, this slide nicely summarizes the vascular distribution, and this should be in your handout. But in complicated cases where you are struggling with the vascular distribution, this is a good reference article. It's called The Supratentorial Arteries by Albert Roton. So if you're looking at a lesion on DWI and you're wondering, is this actually in the MCA and PCA distribution, or is it just in the PCA distribution? This is a good article to refer and to just have it on your laptops to refer in the acute stroke cases. All right, so after you look at the diffusion abnormality on MRI and the symptom onset is sudden and it isn't a vascular distribution, you decide it's an infarct. The next question is, how old and large is the infarct? So let's go through the stroke time course. Hyperacute stroke is less than 6 hours, acute is 6 to 48 hours, early subacute and late subacute. As you can see here, the subacute is a long duration. So when we call a stroke subacute, we are actually saying it could be 2 days, it could be 1 week, it could be 3 weeks, or wait a second, it could be 4 weeks. So we actually give them a long time range. And chronic is more than 4 weeks. So can we actually date the infarct reliably on MRI? And the answer is yes. We actually can date the infarct very reliably on MR. So how do we do that? So this table is very helpful in dating the infarct. And so in acute infarct, the ADC is actually low. So, and we already saw an example of that, of the right MCA stroke. In subacute infarct, the ADC can be low, normal, or high. In chronic infarct, the ADC is increased. So if you see high ADC on MRI, you can be sure that this is a chronic infarct or a late subacute, but you're not dealing with an acute infarct for sure. So that is reassuring. Another important thing is flare can be positive or negative. And I'll pause here for a second to emphasize this point. For a long time, it was thought that flare positivity meant that the infarct is subacute. But the recent literature in the last 1 year has shown that flare can be positive between 2 hours to 24 hours. So if we see a stroke with flare, which is flare positive, it does not mean it is subacute. It could be acute. So no patient should be denied treatment of acute stroke if the flare is positive. And this is a relatively new concept which came about 1 year back. So that's why I said positive or negative in acute stroke here. Subacute is usually positive. The flare becomes positive at time. And chronic usually is positive because there's encephalomalacia, volume loss, and gliosis in the area of the infarct. Going to enhancement, usually the Jarry-form enhancement starts in the subacute stage, and then chronically you just see laminar necrosis. So this is a picture of showing how the findings evolve with time. The T2 and flare abnormality increases with time. In the beginning you might not see much, especially if it's just 1 hour old, and then it will increase with time. The DWI increases and then decreases with time. The ADC is low in the beginning and then it increases with time. But again, the question is, can we actually date the infarct? And on the next slide, there are 3 sets of numbers which help us dating the infarcts pretty reliably. First one is ADC. If the ADC is low, you know that the infarct is less than 10 to 14 days old. So if the ADC is low, you know the infarct is less than 10 to 14 days old. If it's high, you know it's more than 10 to 14 days old. That's the first number to remember. Second is pseudonormalization. Pseudonormalization is when the ADC and diffusion become almost normal, and that happens at 4 to 10 days. Enhancement starts at 1 week, and that's another good number to remember. So let's apply this. So this patient came at UCSF. There was no known history. Patient had altered mental status, and they wanted to know what's going on. So we have the DWI, ADC, flare, and post-contrast. On post-contrast, we see Jarry-form enhancement. So based on the previous slide, this looks like an infarct, which is at least 7 days old. There's something very cool going on here. So if you look at the borders of the infarct, you see pseudonormalization. The DWI and ADC are trying to become normal here. And so that means the pseudonormalization usually happens between 10 to 14 days old. So our report was that this is a subacute infarct, which is between 7 to 10 days old. And if you go to the history, they found out some history from the family. This was a 50-year-old female with bicuspid aortic valve endocarditis who awoke with right hemiparesis 8 days. So our range of 7 to 10 days based on the previous numbers was very reliable. This can be really helpful if there are multiple strokes and they're trying to figure out, if they're of different ages and if it actually matches with the clinical history. So yes, we can very reliably date strokes on MRI. This is another patient. So we have diffusion restriction in the distribution of the right MCA. So this is an acute infarct. The flare is not positive here. It's consistent with an acute infarct. On the left side, we have a lot of volume loss, encephalomalacia, and gliosis here. So this is a chronic infarct in the distribution of the left MCA. All right, let's go to the next one. All right, so if we have to decide what is the short protocol for stroke, the most important sequences are DWI, flare, and susceptibility. The DWI helps us decide whether there's diffusion restriction or not. And if the patient is moving a lot, all we need is just a DWI. So that should be the first sequence in every stroke patient. And many of them are altered, so we have to prioritize the sequences. So DWI is the most important sequence. If you have time, you can do flare, just to see if there's any corresponding flare signal abnormality. But as I told you, the significance of flare in dating the infarct has become less important given the literature in the last 1 year. And then susceptibility, because it helps us understand whether there is any hemorrhage. This patient had a right posterior cerebral artery hemorrhagic infarct. We can see the diffusion restriction, but we can actually see the hemorrhage also in the region of the infarct. So after we have decided how old the infarct is, we have to decide how large is the infarct. And why is that important? The DWI more than 70 cc is specific for poor outcomes. Nationwide, there are multiple new trials which are starting for treatment of late acute ischemic stroke. We are entering into a very exciting era of stroke imaging. At our hospital, we have treated 10 patients who are outside the thrombolytic window based on a trial. And the basis is we are selecting the patient based on DWI volumes. And how do we do that? So for example, this patient had a right MCA occlusion, but has a small infarct in the distribution of the right MCA on DWI. And how do I measure volume? We do length by width by the number of slices and divide by 2. That's the same formula which we use for intraparenchymal hematoma volumes. And multiple trials are using that. And why are we doing that? The reason is, if this patient has a right MCA clot, they should have a large infarct in the distribution of the right MCA. But if you look at the infarct, it's just very small here. So if we actually do neurointerventional treatment in this patient, we might be able to save the remaining tissue which is in the distribution of the right MCA. And that is the basis for new trials like Diffuse 3, Dawn, which are coming up, so that we can possibly treat wake-up strokes and late strokes if the infarct is very small on DWI, and we can salvage the remaining part of the tissue. So going back to the 4-question-based approach, we talked about, is this an infarct or MRI? If this is an infarct, how old is it and how large is it? The next question is, can I apply neuroimaging technologies to help in the diagnosis? And I'll start with ASL imaging. And ASL imaging is very exciting because it is basically perfusion without contrast. So most of the times when stroke patients come in, you don't have creatinine available. And the question is, should we get the creatinine, should we wait, or should we just go ahead? But luckily, ASL does not require contrast, so that's good. So let's take an example here. So on DWI, you see multiple border zone infarcts here, on the left side. And on the MRA, the right ICA and the right MCA looks normal. But on the left side, we do not see the left ICA or the left MCA. Now, let's look at the ASL here. So on the right side, there is normal perfusion. But on the left side, we see hypoperfusion throughout the distribution of the left ICA. So this is a nice image showing decreased vascularity, decreased perfusion, decreased blood flow on ASL in the distribution of the left ICA. So ASL can really help us because sometimes the question is it stroke? Is it seizure? And if you have ASL handy, you can actually distinguish that. So because in seizure patients, there should be increased blood flow. In stroke patients, there should be decreased blood flow. So for example, this patient had DWI abnormality in the right hippocampus. But if you look at the ASL, there is increased perfusion. So this is not stroke, but this is actually seizure-related excitotoxic injury of the hippocampus. So ASL can really help us distinguish whether it's actually a real stroke or is it a stroke mimic, like seizure in this case. Another example, this was a patient of PRESS. You see diffusion restriction in bilateral parieto-occipital lobes, a very good distribution of PRESS, and ASL shows hyperperfusion, rather than hypoperfusion, which you see in stroke. So it can be really handy to distinguish between other mimics. Let's go to dynamic contrast, post-contrast perfusion imaging, and this is a chart which you can use both for MRI and CT perfusion. And on here, we have the different stages of stroke evolution. The first here is just, underperfused tissue, but the collaterals are actually compensating. Then there is underperfused tissue, and then there is post-ischemic hyperperfusion. Not complicating this chart, there is just one take-home message from this chart. For a long time, we thought that the MTT should be prolonged in the brain in stroke patients because the blood will flow slower. But as you can see from this chart, depending on the stage of the stroke, MTT can be increased or decreased. So it's important to understand that it can be either increased or decreased. Similarly, CBV, for a long time it was thought that the CBV should be decreased. But again, it can be either increased or decreased. So when I dictate CT perfusion or MR perfusion reports, I usually just call it a defect. I say there's a CBV defect and there's an MDT defect rather than saying it's increased or decreased, because it can be either in stroke patients. And what are we looking for by perfusion? So for example, this patient has a stroke in the distribution of the left MCA, and we can see it on DWI. And here, this is the dead tissue. The question is there some other tissue which is hypoperfused, which we can save? But as we can see here, there is the CBF, the MDT, has a matched defect. So the perfusion is low in the area of the infarct, but there are no other areas which are hypoperfused. Let's go to a different case. Let's go to this case. So this patient has a left MCA distribution infarct, but if you look at perfusion, there is a large perfusion defect in the distribution of the left MCA. So the blue area is the area of the mismatch, which is not dead yet. So diffusion represents a dead tissue, and the perfusion represents the hypoperfused tissue. So the area in blue is the penumbra, or the area of the mismatch, which you can salvage if we go ahead and do recanalization. Yet another example. Here we have a small infarct on DWI, but we have a large defect on mean transit time. So again, the dead tissue represented by diffusion is very small, but if you look at mean transit time, there's a large area of hypoperfusion. So if we go in and recanalize the MCA, there is a large area of penumbra or viable tissue which we can salvage. And multiple new trials, especially in the last 1 year, have shown the significance of neurointerventional treatment. So usually it's a good idea not to wait for perfusion if the stroke is less than 6 hours. If you see no intracranial hemorrhage and a proximal MCA stroke, it's better just even before the perfusion comes back to start activating the neurointerventional pager. Perfusion in brain tumors, I won't go in details because Sumi went over brain tumors, but in brain tumors, usually you see increased perfusion, like in this patient. Vessel wall imaging is also a relatively new technique, and I just wanted to spend a few slides to give an idea of what it actually is. So when we see vessel wall narrowing on MRA, the question always is it dissection? Is it vasculitis? So what is it actually? So vessel wall imaging actually helps us distinguish whether there is athro there, vasculitis, dissection, or RCVS. Let's go over one case here. So right here on the MRA, you see that there is a right MCA narrowing. And then on the vessel wall imaging, you actually see vessel wall enhancement. So you see enhancement throughout the wall of the MCA. And this was a patient of vasculitis and a young patient. Compared to this patient, so this patient had some, narrowing of the right MCA, and there was just hardly any enhancement here. So we said that this is not vasculitis likely, and this patient also underwent follow-up, and this came back to normal. So this was a patient of reversible cerebral vasoconstriction syndrome and neurovasculitis. So we can actually diagnose vasculitis and other etiologies on vessel wall imaging. So coming back to our questions, we talked about how old and large is the infarct, if this is an infarct, and can I apply newer imaging technologies like ASL or vessel wall imaging to help in diagnosis. The final question should be, am I sure this is not a stroke mimic? And it can be actually very humbling, because many times you think it's a stroke, but it is actually a stroke mimic. So, and it's important to remember, all diffusion restriction on MRI is not stroke. So multiple other etiologies cause diffusion restriction on MRI: tumor, seizures, demyelinating, METs, infection, transient global amnesia, and fat emboli. So I won't go into details of tumors because Sumi went over it, but tumors can be confused with infarcts when they present with acute symptoms, because they present with stroke-like symptoms. But tumors are more mass-like and expansile, and in cases of confusion, MR perfusion and spectroscopy can be really helpful. Let's see one case here. This looks like a hyperdense left MCA. But if you see the area surrounding it, it's really swollen, and it is in the distribution of ACA and MCA. We did an MR, and you can see that this abnormality is very expansile. There is expansile abnormality in the insula, and also the anterior temporal lobe. It looks very suspicious. So given this appearance, we were suspicious that this is not a stroke, though the patient had acute onset of symptoms. We also did MR spectroscopy, and the choline was high and NAA was low, consistent with brain tumor. In cases when you're not sure, I think it's better to get follow-up too. Follow-up tumors should increase, and in cases of stroke, there should be volume loss. And trust me, there are a lot of cases which lie in those gray zone of stroke versus tumor. A seizure can mimic stroke. The classic TWI signal abnormality in seizure is in hippocampus. We saw a case of that earlier. Pulvinar of the thalamus can also be involved. Cortical regions are involved, contralateral cerebellar hemisphere, and sometimes you just see one focus of diffusion restriction in the splenium in seizure patients. Usually it's confined to the cortex, and here is an example of the hippocampal involvement in seizures. And again, ASL or perfusion can be really helpful in distinguishing them. Also, the other option, which is an easy option, is just follow-up. So seizure-related excitotoxic injury should completely resolve with time, as if nothing really happened here. So in cases in which there is confusion, about 3 to 4 weeks follow-up is good, because if it completely resolves, it was likely related to a seizure. But if you see volume loss, it is stroke. Transient global amnesia is also an important mimic, and the history is classic. They have sudden onset of profound antegrade amnesia, which resolves spontaneously within 24 hours. So it's very transient. And on MRI, the appearance is also classic. We see punctate focus of diffusion restriction in the lateral aspect of the hippocampus. So right here, there's a focus of diffusion restriction in the lateral aspect of the hippocampus. The rest of the brain was completely normal. The patient had transient memory loss, and this was a patient of transient global amnesia. Multiple sclerosis can show diffusion restriction in active stages and can mimic ischemia. And the distribution of the lesions actually helps, because most of the lesions converge towards the callosocceptal interface. There are multiple periventricular, deep and juxtacortical hyperintense lesions. Usually they have peripheral restricted diffusions, and they have enhancing rim, which is incomplete peripherally. And again, short-term follow-up is helpful in cases where there is confusion. So this is what I was talking about. These patients usually have a peripheral diffusion restriction, like in this particular patient, and these lesions converge towards the corpus callosum and the callosocceptal interface, And this was a patient, and there was some enhancement here. This was a patient of multiple sclerosis with active disease. Metastatic disease is an important mimic of stroke. The presence of vasogenic edema surrounding the larger lesions can be really helpful. Additional sites of disease, whenever there's an MR, we have to look for calvarial lesions, head and neck lesions, globe lesions, to make sure that there is no other areas of involvement. Let's look at one case here. So this patient had multiple foci of restricted diffusion throughout the brain, which did show enhancement. And on the MRI scout image, we saw a lung lesion, and then we ordered a CT chest, and this patient had lung cancer, and these were all metastatic lesions. So though they look like septic emboli or tiny strokes, looking at all the images on MRI to find other clues can be really helpful. Fat emboli, the history is also very classic in fat emboli. It's usually post-long bone fracture or orthopedic procedures, and you see multiple punctate foci of restricted diffusion, and you see multiple foci of susceptibility or microhemorrhages. And it's very classic, and here is a patient of fat emboli. If you look at susceptibility, you see innumerable foci of susceptibility scattered throughout the brain. And all these are microhemorrhages due to fat emboli. And if you see on DWI, you see multiple foci of restricted diffusion. This patient had an orthopedic procedure recently and decompensated and had disappearance. Another disease which can look like this is DIC. So that's an important differential here. And again, just the innumerable foci of susceptibility help us diagnose this with a good history. So summarizing the 4-question-based approach in stroke, the first question should always be, is this an infarct on MRI? Next is how old and large is the infarct? Can I apply neuroimaging technologies for a more accurate diagnosis? And then finally, am I sure this is not a stroke mimic?